Good day. I am tasked to discuss Introduction to Toxicology and Household Poisons. At the end of the session, the student shall be able to differentiate the leading types of toxidromes commonly encountered in clinical practice, identify potential household poisons that may present as medical emergency, in particular when we talk of caustic ingestions that involve either your acid burns or your alkali burns. And lastly, we would recommend public health strategies employing the family focused and community oriented approach to clinical toxicology in the control and prevention of common household poisoning. So let's talk about acute poisoning. Acute poisoning remains one of the most common medical emergencies, accounting for 5 to 10% of hospital medical admissions. Although in majority of cases the drug ingestion is intentional, meaning to say it is not accidental, the in-hospital mortality remains low. Latest epidemiological data would estimate it at less than 0.5%. Notice that when we talk of acute poisoning and when we talk of drug ingestion, if it is intentional, meaning to say there is a desire for the person to take in something in excess that can result in toxicity, it already points to the possibility that there is a psychiatric element that pushes that person to commit non-accidental poisoning. Now, when we talk of acute poisoning, there are specific antidotes available for a small number of poisons and drugs. However, in most intoxications, basic supportive care is the main requirement. Then, fortunately, recovery will follow. When I say basic supportive care, often this would just require perhaps a little bit of hydration using intravenous fluids. We can perhaps sedate the patient if the patient is possibly in pain, or we could provide analgesia and the provision of psychosocial support. Because often these patients who commit non accidental ingestion of poisons or toxins, there is an element that suggests that they are emotionally or psychologically unstable. And so referral to a primary care um, therapist or counselor would be prudent. We can refer them to a clinical psychologist or to a psychiatrist, or to a certain degree, even family and community medicine physicians can also provide primary care counseling that would entail cognitive behavioral therapy. Now, one of the things that we also try to encourage, if, for example, there is external um, injuries, we perform external decontamination. Often, this is very important for acute poisoning, wherein there is involvement of toxins that could have possibly irritated the skin, the eyes, or other external areas to prevent absorption into the body and reduce the harm. The first critical first aid measure should begin as soon as possible, ideally at the scene of the exposure, and is crucial for protecting both the patient as well as the healthcare providers from contamination. I remember when I was still a resident physician trainee at the UP Philippine General Hospital. So, as a family and community medicine trainee, we had a 1 month rotation in clinical toxicology. And when we receive patients who are suspected to be suffering from acute intoxication, let's say, for example, they are covered with kerosene for whatever reason, right outside of the emergency room complex of the UPPGH, we would literally wash the patient, remove the external clothing of the patient, and we would literally bathe the patient. More so if the patient is non non-alert, or for example, when the patient is in a coma or something like that. So the external decontamination is one of the first line interventions that we can provide if you are highly suspecting contamination. So you strip off all the clothings, remove all accessories, and then literally you wash with running water. Or to sometimes it depends on what is the most probable cause of the contamination. We can also sometimes use soap depending on a case-to-case basis. Now, another intervention that we sometimes do is the conduct of a charcoal gastric lavage. Charcoal gastric lavage in the management of acute poisoning refers to a procedure combining gastric lavage, meaning to say you insert a nasogastric tube or an oropharyngeal tube in the for either in the nose or in the mouth, and this will go directly to the stomach of the patient. And then we do washing. We can use either saline solution or whatever necessary agent that we can offer to the patient. There are times we provide activated charcoal, as exemplified by the image over here. Activated charcoal is given via the lavage to absorb toxins in the gastrointestinal tract, thereby preventing further systemic absorption. But be mindful that not all poisoning would require gastric lavage using activated charcoal. There will only be certain known chemicals or substances which would require the giving of your gastric lavage, in particular charcoal. And this is something that you learn if you do clinical toxicology rotation. Do we encourage vomiting? To a certain degree, the answer will be no. It's really case to case basis, depending on what is the offending substance that is potentially the culprit for the type of poisoning in your patient. So, just to give you an idea, this is a maneuver that can be performed at the emergency room to minimize absorption of any other toxin in the gastrointestinal tract, to minimize systemic manifestations in your patient. Now, I want to share with you, just to give you the vicarious experience of going to the UP Philippine General Hospital, in particular the National Poison Management and Control Center. So in the Philippines, correct, I'm not sure if this is still correct, but when I was a resident trainee, it was only PGH that had the National Poison Management and Control Center. But over the year, in the past recent years, it is my understanding that even East Avenue Medical Center also they now have another poison management and control center. So basically, when we talk of toxicology, there is a pun on the word toxicology. And when you say call, it's CALL. Because literally, when you go on a 24-hour duty at the National Poison Management and Control Center at UPPGH, part of our task back then, as early 2000s, we would do teleconsultation. So let's say, for example, if you are somewhere in Davao or perhaps in Antique or in the Zamboanga Peninsula, and there are no toxicologists in your area, you literally call PGH and the resident rotators. We literally have like those card catalogs wherein all identified or commonly encountered toxins, we have like a cue card where we review. And so when they call, we would just literally look for what is the particular agent that is most probably causing the toxicity. And then we would also already give advice over the phone. And that is why, for a time, the pun with the words is we call it toxicology. But looking at the data, the most recent data that I was able to retrieve from the National Poison Management and Control Center, this is um, the pioneer institution that offers clinical toxicology, the data as of 2021 would reveal that when it comes to unintentional poisoning, meaning to say um, it's most probably accidental, the mortality rate per 100,000 population would be just zero point 0.2. And this is as of 2021, quite comparable to other neighboring Asian countries. So when we're talking of accidental poisoning, the data could be a bit erratic, but it's not exactly of critical mass effect from a public health perspective. Now, I want to share this because this might be a future career path for some of you. The UPPGH, as well as the East Avenue Medical Center, offer a 2-year clinical toxicology fellowship training program. So, of course, the pioneer is UPPGH, and then East Avenue Medical Center followed several years later. But after completing your residency training, for example, in internal medicine or general pediatrics or family and community medicine or emergency medicine, adult neurology or psychiatry, all of these training programs could be used as a stepping stone if you want to pursue further training as a toxicologist. And graduates of the fellowship program eventually become part of the PISCOT. This is the Philippine Society of Clinical and Occupational Toxicology, which is a subspecialty organization duly recognized by the Philippine Medical Association. So it's important that you do recognize that in terms of clinical toxicology, the pioneers are the ones coming from the UP Philippine General Hospital. And since we are talking of, let's say, um, non-accidental ingestion or non-accidental poisoning, meaning to say there is a possibility that suicidal attempts have been committed by the patients who ingested excessive amounts of, let's say, a particular drug or agent, then there is a need for counseling as well. And so the UPPGH also offers interprofessional collaboration or even a multidisciplinary team approach when it comes to toxicology. So even advanced toxicology nursing is being offered by the UPPGH National Poison Management and Control Center, because UPPGH recognizes that when we're talking of clinical toxicology, there is a need for interprofessional collaboration. The nurses can provide the needed psychosocial support, or, of course, the supportive care when they provide, let's say, when we're dealing with a comatose individual, what will the nurses do? So, this is something that the UPPGH values so much when it comes to clinical toxicology. So, just wanted to share with you that this is a short course program open to all registered nurses. So there is a possibility for you to pursue advanced toxicology nursing. And if you're going to look at their teaser, it says here the UPPGH is indeed the birthplace of toxicology in the Philippines. So let's talk about clinical toxicology. The general principles of the management of poison patients are diagnosed based on a very well written or elicited medical history, focusing on salient features that would recognize a toxidrome, your physical examination, resuscitative measures, an investigative nature on what could be the possible culprit, and of course, the provision of continuous supportive care. Measures to reduce absorption or enhance elimination of the toxic substance, as well as provision of specific treatments may be indicated in some cases. Now, in the more acute situations, meaning to say, let's within the last 24 to 48 hours, perhaps, sometimes you have to have a rapid response to a patient who presents, let's say, at the emergency room with possibility of poisoning. So some of the interventions that we do are carried out simultaneously. For example, while we're doing external decontamination, we could already insert perhaps the NGT to do perhaps the lavage, or while the patient is being cleansed, immediately after being cleansed, then if there is a need, let's say, to intubate the patient or to hook the patient to a mechanical ventilator, right there and then, these are all simultaneously carried out by an interprofessional team. That is why interprofessional collaboration when it comes to toxicology is imperative. And so this is one of the things that I did learn when I was a resident trainee. Now, in many clinical circumstances, unfortunately, when a patient, especially who is stuporous or in a coma, whenever they present at the emergency room, you don't know what poison triggered the cascade of symptomatology. So if you are the emergency medicine physician, then the relatives will say, naglason ho, uminom ng lason. You don't know what particular poison did this patient consume. Is it, I don't know, is it liquid sosa? Is it muriatic acid? Is it an insecticide? We don't know. And so we need to have the clinical eye to determine what is the most probable or what is the logical culprit or substance that was taken by the patient, and you come up with a logical algorithm based on symptomatology. So in these circumstances, after appropriate life support measures have been instituted, the toxic treatment paradigm would ensue, wherein we group signs and symptoms to come up with the most probable toxidrome. A toxidrome will classically describe clinical presentations common to a number of toxins. So again, a toxidrome is a recognizable set of signs and symptoms that would help healthcare providers rapidly identify the class of drug or toxin responsible for poisoning. When I say symptoms, symptoms often refer to the subjective complaint of the patient. Let's say if the patient says, "Oh, my tummy hurts, my head aches." So these are all symptoms. On the other hand, if symptoms are subjective, clinical signs are objective findings that are determined by a healthcare provider, whether it is a nurse or a physician. Let's say, for example, if you determine the blood pressure, if you put the patient on a pulse oximeter, you determine level of oxygenation. These are all clinical signs. So if you combine the subjective symptoms with the objective signs, we can come up with your toxidromes. So recognizing a toxidrome will guide the differential diagnosis, allow faster initiation of targeted treatments, is including the administration of known antidotes and supportive care, even before laboratory or diagnostic workup results are available. Let me emphasize that not all poisoning would have antidotes. There would be some that would have the classical symptoms. For example, when you have opioid toxicity, the most commonly identified antidote for opioid toxicity would be naloxone. So again, you will encounter these agents when you go to second year during your pharmacology. I'm just highlighting that be mindful that there are toxins or there are poisons with corresponding antidotes, but not all. Now, again, why is it imperative that we are aware of the toxidromes? First, for rapid diagnosis, toxidromes will help identify the likely poison class in an emergency situation, which is critical, especially when the patient will be unable to communicate or provide details about their exposure. You can also provide focused treatment. Meaning to say, when you are able to properly identify a toxidrome, healthcare providers can provide the needed treatment if necessary. For example, your antidotes, or if, let's say, there is a need to intubate the patient and hook the patient to a mechanical ventilator, if there is a need to decontaminate externally, then these are things that you can already do. And of course, it helps direct which additional laboratory tests might be useful to further describe the prognosis or the progress of the type of acute poisoning. So let's talk about toxidromes. Now, there are many types of toxidromes, but the more commonly encountered toxidromes would be your anticholinergic toxidrome, your cholinergic toxidrome, opioid toxicity, your sympathomimetic toxidrome, and the toxidromes related to your sedative hypnotics. Normally, if you look at all of these, you can already have a fair idea of what particular toxidrome a patient would have if, let's say, you look into the vital signs, heart rate and blood pressure. When you auscultate the lungs and listen to the breath sounds, if you check the patient's temperature, if you have a pen light and you're able to look into the pupils of your patient, whether there would be dilated pupils or very small pinpoint constricted pupils, or when you listen to the bowel sounds in the gastrointestinal tract, or you describe the extremities of the patient. Is there excessive sweating or diaphoresis, or is the patient really dry? So, by just eyeballing, you will already have an idea of what particular toxidrome you're dealing with. However, guidelines from the Department of Health and, of course, from the National Poison Management and Control Center would tell us that whenever you are dealing with a patient who is suspected to have acute poisoning, wag na magpatumpik-tumpik pa. You need to bring the patient promptly to the nearest hospital, if possible, a tertiary hospital that could be able to provide holistic care for your patients. This is a relatively old infographic, but I think I'm saying this infographic is old because it only has 7 digits for the landline. Since pre-pandemic, we already have 8 digit landline. So I know for a fact that this is an old infographic, but the content remains true. And of course, later on, I will give the new number of the National Poison Control Center at the Philippine General Hospital, which offers um, telephone assistance or telemedicine consultation um, 24/7. And this is something that is quite useful, especially for those in other parts of the Philippine archipelago where there are no toxicologists in their area. So let's go over the toxidromes one by one, beginning with anticholinergic toxidrome. By far, this is the most common toxidrome identified. Anticholinergic toxicity is defined more appropriately as your antimuscarinic poisoning. And an important finding or a clue would be if a patient would present with very fast heart rate or tachycardia. And if you check the skin, it's dry. This is something that is commonly encountered in an anticholinergic toxidrome versus that of an adrenergic toxidrome, which I will discuss in brief in a short while. Now, your anticholinergic toxidrome would also present with central and peripheral manifestation. As the name implies, when you talk of central involvement, what is most commonly affected will be the brain and the spinal cord, referring to the central nervous system. Ergo, there could be altered mental status, there could be disorientation, agitation. Sometimes your patients will present with hallucinations. A patient could be very drowsy or lethargic, and sometimes, if it's quite severe, it can also precipitate your seizures and convulsions, and sometimes push a patient to go into in a coma state. In contrast, peripheral symptoms and signs would include changes in the skin. The skin would be very dry. There could be vasodilation in the blood vessels. That's why you would see a little bit of flushing. And when you touch the patient's skin, it could be a bit hot, suggestive of blood pooling, but of course it lacks sweating or their condition which we call their anhydrosis. Mydriasis is when you have um, dilated pupils, which can also result in blurring of vision and photophobia. The other mucosal membranes, such as the lips, the mouth, or the tongue, would be very dry. There could be problems with the genitourinary tract, as well as problems with thermoregulation, and of course, even the heart rate could be affected. Now, anticholinergic toxidrome is characterized by the following. You have altered mental status, hence we call it the mad as a hatter. There could be mydriasis, so you might be unable to visualize properly, so you're blind as a bat. There would be erythema or redness or hyperemia of the skin, so that you could be red as a beet, suggestive of flushed skin. And there would be anhydrosis or dry skin, hot as a hair, and of course, dry as a bone. If you look at the mucosal tissues, there would be drying. Now, for most anticholinergic toxidromes, surfisostigmine is the known antidote. So I'm just saying it here. You don't need to know the mechanism of action of your physostigmine. You will encounter this again when you go to pharmacology and sophomore year. We now move on to your cholinergic toxidrome. Often, your cholinergic toxidrome happens when there is insecticide ingestion. When I talk of insecticides, there are different classes of insecticides. This picture, which is the green bygone, it is usually because of an organophosphate. But be mindful that there are other types of insecticides. The blue bygone, this is your pyrethroids. When I say pyrethroids, they usually come from the composite flowers for the biology majors or the botany majors. Your composite flowers are the ones that you call your that will produce your pyrethroid insecticides. Now, chrysanthemum is one example. And then you have the organochlorines and the carbamates. So depending on what type of insecticide you're using, organophosphates, organochlorine, carbamates, or your pyrethroids, often, but not always, they would present with your cholinergic toxidrome, in particular, your organophosphates and your carbamates. The cholinergic toxidrome is manifested by signs of stimulation of the muscarinic and the nicotinic receptors in the autonomic and somatic nervous systems. Now, agents that cause a cholinergic toxidrome can be divided into two main groups based on their mechanism of actions. There are those that cause direct nicotinic receptor stimulation. Example would be plant alkaloids or your nicotine-based insecticides, and those increase your acetylcholine levels. This would include your organophosphates and your carbamates. Often, your cholinergic syndrome is secondary to your organophosphates and your carbamates. Now, there is a mnemonic for you to remember what are the common signs and symptoms of your cholinergic toxidrome. So again, some of your some of your insecticides can come from flowers or sometimes from the ones that we use for flowering plants, or sometimes if you want to control the bee population. So the mnemonics would be that of your sludge and your dumbbells. So again, just for your perusal, I tried to look for an infographic that would help you remember what are the common, the myriad of symptoms that you, signs and symptoms that you might encounter if you're dealing with a cholinergic toxidrome. And that would be the dumbbells and the sludge, depending on what particular um, receptors or what particular receptors are being targeted by the toxin, whether you are talking of the muscarinic or the nicotinic receptors. Then we go to your adrenergic toxidrome. This is a distinct clinical syndrome caused by excessive stimulation of the adrenergic sympathetic nervous system due to exposure to substances or drugs that increase adrenergic activity. Now, your adrenergic toxidrome can be caused by overdose or poisoning with substances, which would include your shabu or your amphetamines, cocaine, epinephrine, sympathomimetic bronchodilators, and other stimulant drugs. Symptoms of your adrenergic toxidromes will occur due to excess norepinephrine and epinephrine-like effects on the cardiovascular system, the central nervous system, and other organs of the senses, no? Eyes and among and other organs, just to mention a few. So if you will recall when we were having that um, era of extrajudicial killings or the Operation Tokhang, most of the victims of the alleged Tokhang the violence related Tokhang events, they were all blaming amphetamine abuse and cocaine use as the main street drugs that are producing the toxidrome. I believe you have another lecture given by our department chair, Dr. Wanko, on substance use and abuse. So I'm not sure if he tackled these drugs, but amphetamine and cocaine are quite notorious in causing your adrenergic toxidrome. So, just to highlight what are some of the more common agents that can precipitate an adrenergic toxidrome, this would include your recreational drugs, even your ecstasy and other designer drugs, even the ones for bronchial asthma. Your salbutamol and your theophylline, these are your short acting beta agonists, inotropic agents that would improve on the cardiac contractility, your norepinephrine and your epinephrine, even those that you see in over-the-counter nasal agents. For example, oral decongestants, no? The over-the-counter decongestants and anti-cold pills, no? Which would contain phenylpropanolamine or pseudoephedrine, and of course your amphetamine-like agents um, that are these are sometimes referred to as the precursors of your methamphetamine. Methylphenidate, for those who are occupational therapists or physical therapists and speech pathologists who work with children belonging to autism spectrum disorder. Some of our DevPed doctors would prescribe methylphenidate for patients with autism spectrum disorder or with attention deficit hyperreactive disorders. So, for example, I have a nephew who used to be on methylphenidate when he was younger. So, for example, you can't bring your methylphenidate to Japan or Korea, even because it's a regulated drug in those countries. So, just to give you an idea of some of these drugs are actually being used today to address certain common medical conditions. So, just to highlight that these can all cause your adrenergic toxidromes. So, what are some of the clinical manifestations associated with your adrenergic toxidromes? There could be agitation, anxiety, restlessness, tachycardia, palpitations, hypertension, mydriasis, hyperthermia, diaphoresis, tremors, possible chest pain, and even cardiac dysrhythmias. And you could have hyperreflexive patients. But the good news, there is not really the good news, but the thing with your adrenergic toxidromes, these are commonly encountered toxic poisoning, but there, unfortunately, we do not have specific antidotes for them. But management would basically include regulating the temperature, lowering it down to the normal levels, addressing hypertension, and sometimes we can give sedatives just to calm the brain. One of the more commonly used would be your benzodiazepines. This would include your alprazolam, clonazepam, and other supportive measures that would improve on the quality of life of your patients, especially if they are admitted in the service wards or in the wards. Then you have your GABAergic toxidromes. A GABAergic toxidrome is a clinical syndrome resulting from the excessive activation or potentiation of your GABA, which are inhibitory neurotransmitter receptors found in the brain and the spinal cord. Now, when we talk of the GABAergic toxidrome, this toxidrome typically is noted with overdose or toxicity of drugs that enhance GABA activity, in particular your benzodiazepines and your barbiturates, including other sedative hypnotics. So these are basically neuropsychiatric agents. Benzodiazepine is a very sedating antipsychotic agent. So examples of which will be your clonazepam and your alprazolam. I'm not sure if you will still remember, maybe for those who with a degree in pharmacology, yung nauso before, no, yung ativangang, you can Google that. What is the ativangang? This is what with the date rape drug. So with, sometimes people would be they would drug the drink, and so when you drink let's say a cocktail with your ativan, so that is your lorazepam, they just literally fall asleep, and then the next thing they realize they're perhaps in a motel completely naked and they have been gang raped already. So those are the date drugs that we used to have in the Philippines, but ativan or lorazepam has been phased out already. Barbiturates are often used for other um, neurologic conditions. In particular, sometimes there could be still a role for seizure disorders. Now, because the mechanism of action of these agents will be on the brain, the syndrome reflects the inhibitory effects of GABA, leading to CNS depression. And of course, we do know that the brain is pivotal in producing motor function. So those are the symptoms that you might commonly encounter with your GABAergic toxidrome. So just to highlight, there could be CNS depression ranging from drowsiness to deep coma. There could be very flaccid muscles, hypotonia, to the point that ambulation could be challenging. There could be ataxia or those involuntary jerky movement because you lack the coordination. There could be slurring of speech, respiratory distress, and of course, there could be subtle changes in the vital signs, and in severe cases, it can even push stupor, coma, and even respiratory arrest in some patients. Then we move on to your serotonin syndrome. This is potentially life threatening, and it is because of toxicity secondary to your serotonergic drugs. These are more commonly encountered for your antipsychiatric agents, your SSRIs, your MAO inhibitors, or tricyclic antidepressants, certain migraine medications, in particular your triptans. Again, for the pharmacy majors, you might be aware of your sumatriptan, that's a migraine medication, and of course the recreational drug. And I refer you back to the lecture of Dr. Wanko when it comes to recreational drugs, which are considered substance of use and abuse. Now, the diagnosis of your serotonin toxicity is primarily clinical, meaning to say you rely on history and physical examination, and there is a clinical algorithm that most clinicians follow for you to come up with a competent diagnosis of your serotonin syndrome. Colonus, which is basically uninducible, spontaneous, and um, abnormal movement is quite particular when we talk of serotonin syndrome. For example, if this is the hand, if I give a gentle push, this would suddenly have that movement. So you induce the involuntary movement, and that clonus, you can elicit it either in the upper extremities or in the lower extremities. This is highly suggestive of your serotonin syndrome if there is clonus. Now, just to highlight once again, what are some of the myriad of symptoms that you will present that you might recognize when you have serotonin syndrome. So, just to give you a rundown, I won't really dwell on these signs and symptoms, but I would highly encourage that you read on these. So, I was mentioning about the algorithm for serotonin syndrome. So, this is the algorithm for the diagnosis of serotonin syndrome. So, again, just for academic purposes, I'm presenting this to you. If ever you do pursue toxicology in the future, you might be more in depth or more at ease with the use of the algorithm. But just to highlight again, there is a mnemonics for the serotonin syndrome, which is shivers. And these are some of the more commonly encountered agents that can produce your serotonin syndrome. That will include your antidepressants, your analgesic agents, your antiemetic o yung para wag magsuka, and your recreational drugs, which would include your shabu and your ecstasy, and among other things, your linezolid is one of the classes of antimicrobials or antibiotics that you might encounter in the future when you do your clinical rotations. So treatment is essentially supportive. We just give intravenous hydration and we do close monitoring. We remove any precipitating drugs to manage the CNS manifestation of agitation, autonomic instability, and hyperthermia. There is an antidote or more of an agent that could reverse the symptoms of your serotonin um, syndrome, and this is your 5-hydroxytryptamine type 2A or your 5-HT2A antagonists. I'm not sure if you are familiar with the photo that I'm showing, but I do know for a fact that among the, I won't say naman, but for the elite younger generation, I remember when I was still way back in way back in college. So my high school friends from Ateneo would tell me that they would go into parties before or clubs in Makati or in Pasay or in now it's in BGC wherein they would have a pill party. When you say a pill party in a bowl, in a fish bowl, there are different unknown drugs. Some of them look like candies, such as the photo being shown here. And literally, they pass around the fishbowl and everyone gets something. So you don't know what particular drug is going to hit you, but that would be the name of the game. So it's something that the more affluent younger people would do because some of these party drugs are quite expensive. So just to give you an idea that this is something that is quite serious from a public health perspective. So I've talked about life in PGH. And just to give you a vicarious experience, in 2024, the leading causes of poisoning among inpatient referrals, meaning to say those who were admitted in the wards, among the adults, it would include your methamphetamine, your shabu, paracetamol, ethanol or alcohol, sodium hypochlorite, which is your bleach, hydrochloric acid. Um, this is usually your muriatic acid, mefenamic acid, and ibuprofen. These are commonly prescribed or over the counter non-steroidal anti-inflammatory drugs. Escitalopram it's an anxiolytic anti-anxiety drug. Clonazepam is a benzodiazepine, and chlorpheniramine is an agent that you normally see in your over-the-counter nasal decongestants. In the pediatric group, paracetamol, that's the most popular antipyretic agent, sodium hypochlorite, your bleach, which is basically an alkali, your chlorpheniramine and your phenylephrine, um, nasal congestants, decongestants, escitalopram, iron, surfactants. Surfactants are basically like cleaning agents. Multivitamins, hydrogen peroxide, mefenamic acid, and quetiapine is also it's a psychiatric drug that can also precipitate sleep among patients suffering from primary insomnia, but it's more of it's an anti-anxiety, antipsychotic agent. So this is for the inpatient referrals based on the data of the National Poison Management and Control Center of the UP Philippine General Hospital as of 2024. Now, when it comes to outpatient, meaning to say these are patients who did not end up in being admitted, but we also have the following: paracetamol, ethanols, sodium hypochlorite, surfactants, clonazepam, snake bites, which are non-venomous, hydrochloric acid, chlorpheniramine, and cypermethrin is more of an agricultural insecticide, and escitalopram. I want to talk some, because I am a tropical medicine graduate. We do have a lot of lectures, or we did study snake bites. And I was fortunate to also have a clinical rotation at the Research Institute for Tropical Medicine in Alabang. And in the Philippines, we only have three classes of your venomous snakes. The first one will be your cobras. Among the cobras, you only have one genus and several species. The more popular one would be your Naha Naha. That's your Philippine cobra. Then you have your Naha samarensis. That's your Samar cobra. Then the second class would be your vipers, in particular your pit vipers. For those of you with biology background or zoology background, if you are familiar with the arboreal pit vipers of Batanes, so these are nocturnal arboreal snakes that live on treetops. You have the albino white pit viper, the yellow pit viper, the brown pit viper, the spotted pit viper. So those are the pit vipers. And the last would be your sea snakes. In particular, we only have one genus of your sea snakes endemic in the Philippines. This is the sea snake that you find in Taal Lake in particular. So if the bite is not from a cobra, from a pit viper, or from a sea snake, chances are it is non-venomous. If it's a python or a boa constrictor, chances are these are non-venomous snakes. That is why they don't need to have admission. We only have one antidote or antivenin or antivenom for the venomous snakes. It's specific for cobra, in particular your Naha Naha, but sometimes we use it for your Naha samarensis bites, or for your pit viper bites, or for your sea snake bites. But if you're going to be very particular about it, let's say, for example, if you go to Australia, where there are also a lot of poisonous snakes. For each different genera of venomous snakes would have different antivenin or antivenom, just so you know. And then for the pediatric population, paracetamol, sodium hypochlorite, multivitamins, surfactants, chlorpheniramine or chlorphenamine, phenylephrine or phenylpropanolamine, isopropyl alcohol, ethyl alcohol, iron, and even kerosene. Now, when I was a resident, one of the more commonly encountered agents that precipitated acute poisoning was jewelry cleaner. But within the last 5 or 10 years, nagbago na because PISCOT, the Philippine Society of Clinical and Occupational Toxicology, they started to ban the use of the cyanide-based jewelry cleaner. In particular, yung mga nabibili na tingi-tingi sa Divisoria or sa Quiapo, the jewelry cleaner, in particular those that clean your gold and your silver jewelry, they may contain cyanide or it could be non-cyanide based. But because of the warnings of PISCOT in partnership with the Philippine Drug Administration, we started to regulate those jewelry cleaners. So now, if you look at the top 10, wala na dyan. But the thing with your jewelry cleaner, it is usually odorless, colorless, tasteless. Very much like your typical glass of water. And when you buy the jewelry cleaner, iting-iting sa yung suking tindahan in Quiapo or in Divisoria. Normally, they would just put the jewelry cleaner in your regular PET bottles na parang distilled water lang. And a lot of kids would assume, oh, it's odorless, colorless, tasteless. They will drink thinking it's just water, when in reality, it is also your jewelry cleaner. And so before, pre-pandemic, your cyanide was in the top 10, most probably because of jewelry cleaner. But now, it's no longer in the top 10 leading causes of poisoning at the Philippine General Hospital. So I want to focus our attention on your sodium hypochlorite because this is the one that is leading in terms of commonly ingested, whether pediatric or adult, whether inpatient or outpatient. So what is sodium hypochlorite? It is a bleach and it is an alkali and it can cause caustic ingestion. Caustic ingestions are secondary to acid or alkali burns. So these are just some of the more commonly encountered burn lesions that you might see in patients who suffer from caustic ingestion. Caustic ingestion refers to the accidental or intentional swallowing of corrosive substances, in particular your strong acids or strong alkalis, which can precipitate chemical burns and damage the tissues of the upper gastrointestinal tract, to include the mouth, the esophagus, and the stomach. Now, the gravity and the severity of the injury would depend on the nature, the concentration, the amount of substance ingested, as well as the duration of contact. However, upon intake, immediately there would be mucosal burns, there would be swelling, pain. Patient would have hypersalivation or drooling, vomiting, which can eventually cause airway compromise, resulting in difficulty of breathing. If neglected, long term complications will ensue, and this will include your esophageal strictures, stenosis, chronic pain, or because there would be inability to feed properly, it can also result in malnutrition. And to a certain extent, it likewise increases the risk for the development of esophageal cancer. Most patients who suffer from caustic ingestion would require endoscopy. When I say endoscopy, you literally insert a tube with a camera, either in the mouth or in the nose or any orifice for that matter. It can be via the rectum. So we perform an endoscopy to actually check the mucosal lining inside these viscous or in these hollowed organs. Now, for your hollow organs, let's say your esophagus, your gastric chamber, your intestines. So that is why you need to perform endoscopy. Now, again, just to highlight, so we can differentiate your acid burns from your alkali burns. Acids would typically result in coagulation necrosis with protein precipitation that eventually results in eschar formation. The eschar would limit deeper tissue damage, ergo, often the one that is affected would be the stomach. In contrast, alkalis would result in liquefactive necrosis with saponification of lipids, which can precipitate deeper tissue penetration and more extensive injury, in particular to the esophagus. I will not discuss these in further detail. I just want you to identify that there is a difference between your coagulation versus your liquefactive necrosis. You will encounter these terminologies in sophomore year when you go to pathology, but I just have to explain to you that this is something that you might encounter when you're dealing with caustic ingestion. So, what are the different household poisons that we can identify? So there would be several of them. The acids, which will include your toilet cleaner, hair color or dye, phenols, antiseptics, sterilizing solutions, your table vinegar, food colors, and of course, your muriatic acid or your hydrochloric acid. Alkalis would include your sodium hypochlorite, which is in the top 10 leading causes of poisoning in the Philippines. This is your bleach. Your liquid sosa is your sodium hydroxide, hydrogen peroxide, shaving gel or foam, aftershave lotion, hair remover, shampoo, shower gel, mouthwash, any soap, fabric conditioner, your jewelry cleaner, which would include either your cyanide or your non-cyanide base, and your liquid lime, which is your calcium hydroxide. We also have your volatile substances. This would include your mothballs, your paint thinner, um, petroleum, and kerosene. Then others would include your nail polish, acetone, the button. If you are familiar with the solid form of your calcium hydroxide, they call it the button, or even the batteries that you see in your watches or in your gaming consoles, perhaps, or even glue. These are all considered potential household poisons. So since sodium hypochlorite rather, is one of the leading causes, I felt it was imperative that they talk about caustic ingestions of your strong alkalis and your strong acids. Let's begin with your sodium hypochlorite or your bleach, which is an example of an alkaline solution. Strong alkalis cause tissue damage once again by liquefactive necrosis, which involves saponification of fats and solubilization of your proteins, leading to your cell membrane disruption and deep tissue penetration. The hydroxide ions will react with tissue collagen, causing swelling, thrombosis, and heat production. Again, I'm just giving you an overview. You will encounter these in further detail when you go to pathology rather, or internal medicine or surgery in sophomore year or third year medical school. The esophagus is the most commonly effective organ, but of course, other parts of the gastrointestinal tract, including your oropharynx and your hypopharynx, can sometimes be involved. Now, usually, there would be extensive burns and it can cause airway obstruction. Sometimes the burns can also cause perforation of the esophagus or worse, sometimes even stricture. So there would be narrowing of the passage. Sometimes it could result in difficulty with swallowing because the passage has been significantly narrowed already. So there could be pain, dysphagia, or difficulty with swallowing, long-term strictures, even increasing the risk for esophageal cancer and perforation. Some of the clinical symptoms of caustic ingestion with strong alkali would include, aside from the pain, hypersalivation, dysphagia, difficulty with swallowing, vomiting, and respiratory distress. So how do we manage it? We do not induce vomiting. We do not insert a lavage to perform activated charcoal lavage. Sometimes we can also use milk or water if you want to neutralize, assuming you catch the patient early. Or if there is a need for airway management, if there is a need for intubation or hooking a patient to a mechanical ventilator, then these are some of the things that you need to do. And sometimes referral to general surgery. If you're highly suspecting possibility of perforation then or stricture, you might want to refer them to your friendly surgeons. Now, in terms of long-term survival or prognosis, it is dependent on the volume and concentration ingested, as well as the depth of the injury. Superficial burns can cause strictures, but deeper burns have a higher risk. Moving on, we now go to your strong acids. The most common would be your muriatic acid. So again, your strong acids will cause tissue damage primarily by coagulation necrosis, which results in protein denaturation and the formation of your scar. And of course, the acid injury could be limited to the stomach. Now, examples of your strong acids would include your muriatic acid or your hydrochloric acid, sulfuric acid, nitric acid, and your acetic acid. I remember for acetic acid, no, for those of you who went to UP Diliman, I can't remember if it's Chem 26 or Chem 31, where we used to use glacial acetic acid and we have to work under the hood. So imagine you ingesting glacial acetic acid. So your vinegar is an example of your acetic acid. But of course, the vinegar that we use in everyday kitchen or cooking is more or less not as potent as your glacial acetic acid. So these are just some of the clinical features associated with caustic ingestion with strong acids. I will just let you read on these. Hematemesis refers to vomiting of blood or blood-tinged vomitus. Now, complications, there could be gastric outlet obstruction because the pylorus in the stomach could be scarred. There could be esophageal perforation. It can precipitate peritonitis or mediastinitis, and even multiple organ failure that can result in shock. There could be strictures, and of course, the risk for esophageal carcinoma will still be there. Management, just like with your caustic ingestion with strong alkali, we do not induce vomiting or perform gastric lavage. Activated charcoal is also not useful, and basically, we just ensure airway is intact and we provide supportive care, and sometimes referral to the surgeon is warranted. Again, prognosis would depend on the acid concentration, amount ingested, and time to treatment. Large volume or concentrated acid ingestion will carry a higher risk for severe injury and, to some degree, sadly, even premature demise of your patient. I want to share this quote from Dr. Carissa Giuchino Maligaso. So, Ma'am Carissa was my mentor when I was a rotator in PGH. So, Ma'am Carissa is a neurologist, but she did her subspecialty fellowship in toxicology. And she is currently, to my knowledge, until this day, the chair of the Department of Clinical Neurosciences of both the UP College of Medicine and the UP Philippine General Hospital. And she used to be the past president of the Philippine Society of Clinical and Occupational Toxicology. This was published in the Philippine Star way back in 2022, if I'm not mistaken. And she says, we advise every family to be aware of the potential hazards in their household and community and to take preventive measures that will protect everyone, especially young children, from poisoning agents that can be ingested, inhaled, absorbed by the skin, or splashed in the eye. There really is a need to poison proof our homes, as most childhood poisoning incidents occur at home. So if you read between the lines, from a preventive dimension, we empower families and communities to be vigilant in how to address the public health burden of toxicity or accidental poisoning. And the PISCOT, under the presidency of Ma'am Carissa, they came up with ways on how to minimize or to prevent and control household poisoning. Handle, use, store, and dispose of products safely at all times. Seek out eco-friendly products that do not contain hazardous substances. Read product labels carefully. Be mindful of hazard pictograms and precautionary warnings and follow safety instructions. Return all products to their proper storage immediately after use. Never place poisonous products in beverage and food containers and keep them in their original containers. The reason behind this was the multiple incidents of putting your jewelry cleaner, which contained cyanide, in PET water bottles. So mga basyong distilled water or mineral water na pinag-inuman, doon ilalagay, i-refill, gagalagay ng jewelry cleaner. So that's the reason, that's the rationale behind this recommendation. Store food and potential poisons in separate cabinets. Do not mix household cleaning products together to prevent the formation of dangerous fumes. Never reuse pesticide and other chemical containers for storing food and water. Keep medicines, bleaching, and cleaning and laundry products, including e-cigarette liquid refills, insecticides, paints, varnishes and thinners, and car maintenance materials out of children's sight and reach. Never allude to medicine as candy or chocolate or any other name that could be appealing to a child and eventually result in swallowing. Safely get rid of unused, unwanted, or expired medicines, vitamins, and supplements. And wash children's toys and other playthings regularly to lessen the risk of ingesting lead containing dust and other environmental pollutants. Teach kids how to safely use art materials, including your crayons, watercolors, glues, and other adhesives. Then remind them not to eat or drink while doing their art assignments. Secure the battery component of games, toys, and other items powered by small button cell batteries, which can result in choking and chemical risk if accidentally ingested. Be aware of plants inside the house, outside your homes, as some of them may be poisonous to children as well as pets. Because the Christmas season is nearing, for the biology and the botany majors, I'm sure you would remember that your poinsettia. I can't remember if poinsettia belongs to family Euphorbiaceae, but your poinsettia is considered a poisonous plant. But it's very good looking, especially during the holiday season. But be aware, be careful and cautious that your poinsettia is a potential plant poison. This would also include your tuba-tuba, your jatropha poisoning, among others. And you have your angel trumpets. So these are some of your the tura metel. These are some of the more commonly encountered plant poisons, or even some of your cannabinoids. So, for example, if you go to countries where cannabis is legal, for example, if you go to Bangkok, or if you go to other parts of Europe, you will encounter pubs or bars that allow, or even in certain states in the US, your medical cannabis is legally allowed. So it can also cause your plant poisons. And of course, from a public health perspective, you want to empower the entire community. If someone has been exposed to a poison, call the UPPGH National Poison Management and Control Center. So this is the new mobile number. I'm not sure if this is still correct, but this was the one that I got from the 2023 2022 article printed in the Philippine Star during an interview with Dr. Joquino, Ma'am Carissa, and this was the number that was given. So from a public health perspective, you really want to ensure that whenever we talk of poisons and toxicology, call the experts immediately. Bring the patient suspected of acute poisoning to the nearest medical facility the soonest possible time. Access to toxicologists is just one phone call away, and I think this is something that you really need to educate the general public. So, in summary, what have we discussed with our lecture this today? We've talked about the various toxidromes. We've talked about medical emergencies related to clinical toxicology, in particular, your caustic ingestions with either your strong acids or your strong alkalis. And of course, based on the recommendations of the PISCOT, the Philippine Society of Clinical and Occupational Toxicology, there are interventions or measures that we can do at the setting of the home, encouraging family focused healthcare and tapping community resources. Even if you belong to the geographically isolated and disadvantaged area, if there is a need to call a toxicologist, it's basically just one phone call away. I'm not sure if East Avenue Medical Center also offers the same telemedicine consultation platform, but I do know for a fact UPPGH to this day offers this particular service. So I believe this is my last slide, and I want to thank you all for your kind attention and for listening to the lecture for today.